Acute bronchiolitis. It is one of the most common cause of acute lower respiratory infections in infants. It usually occurs during the winter and the spring, and the most common age group which is affected due to acute bronchiolitis is between the 1 month to 2 years. If we talk of the causative organisms, respiratory syncytial virus is the most common one which leads to the bronchiolitis. Others which are commonly involved include the parainfluenza, adeno, influenza, and mycoplasma pneumoniae. The protection against RSV is mediated by the antibodies of IgG3 subclass, but they are short-lived. They do not cross the placenta, so even the infant is very prone for the infection. Now, if we talk of the pathogenesis, what occurs is whenever there is an infection due to this viruses, they will lead to the inflammation of the bronchial mucosa. This inflammation of the bronchial mucosa will lead to the thickening of the bronchial walls. So there will be edema and spasm of these bronchial walls, and there may be the plugging of the secretion, which will lead to the mucus plugs and cellular debris into it, leading to the clinical presentation of the bronchiolitis. If we talk of prognosis, usually it's a self-limited illness where the symptoms will last for 3 to 7 days. But in certain cases in which the respiratory failure occurs due to the severe hypoxemia and acidemia, it may lead to the respiratory failure and death. And few patients of bronchiolitis ultimately progress to develop the asthma. If we talk of DDs which closely mimic the bronchiolitis, they usually are pneumonia, which mimics the bronchiolitis. It may be congestive cardiac failure, maybe foreign body, or it may be asthma. Now, if we talk of the clinical features of bronchiolitis, it usually begins as an upper respiratory tract infection. Soon the infection will spread to the bronchioles. Once they will spread to the bronchioles, there will be high-grade fever, rapid breathing, and respiratory distress. Due to the bronchial thickening and bronchospasm, and a little reduction in the radius will lead to the very high resistance, due to which the child will develop the retractions of the lower intercostal spaces, suprasternal notch, and after such retraction, there may be nasal flaring, grunting, and cyanosis may be evident. If we auscultate, the expiration is prolonged. There may be audible crepitations and rhonchi, which can be auscultated. Also, in some cases, the breath sounds are faint. At times, the air gets trapped. If it is partially trapped, it will lead to the emphysema. If it is completely obliterating the airway, it may lead to the atelectasis. And due to this hyperinflation, there is a pushing down of the liver and spleen. Also, there is increase in AP diameter. Now, if we see the lab investigations on X-ray, there may be hyperinflation. There may be translucent fields which can be evident. Infiltration may be there, bilateral, and a diaphragm is pushed down. On CBC, we can get elevated WBC counts, but they are not usually neutrophilic. On nasopharyngeal aspirate, we may be able to identify the presence of the respiratory syncytial virus. Now, if we talk of the management of the bronchiolitis, the treatment is entirely symptomatic. The child should be nursed in the humid atmosphere and should be kept in the reclining position, that is the head end elevation of 30 to 40 degrees recommended. And the infants with mild disease usually get okay with the humidified atmosphere treatment and propped up position. But in certain cases, if there is a mild respiratory distress, there may be a need of moist oxygen inhalation to maintain the saturation above 92%. There may be a need to manage the fluid and electrolytes. There is usually no role of antibiotics, but in certain cases, like in the case of congenital heart disease, in case of chronic lung disease, or in primary immunodeficiency, we may need antivirals like ribavirin to manage the patient, which is given by the nebulization for 16 hours per day for 3 to 5 days. The role of bronchodilators or systemic steroids or epinephrine is very controversial. They may or they may not benefit. The role is not established, but hypertonic saline nebulization is found to be effective in certain cases. Also, in sick children who need more respiratory support, we may take the use of the CPAP, ventilation, or ECMO.